Welcome back to the Deep Dive. Today we are shifting gears a bit. We're going into full-on high-yield revision mode.
We are.
We're tackling a topic that's absolute bread and butter in the emergency room. But, let's be honest, can be a minefield for the board exams. Orbital and blowout fractures.
Exactly. And this session is specifically for all of you plastic surgery residents out there gearing up for the FRCS or, your local equivalent.
So we're going to treat this a little differently. This is not going to be a casual chat.
No, this is designed to be a rapid-fire revision tool. We're stripping away the anecdotes, the war stories, and focusing strictly on the facts. The measurements, the decision trees.
The stuff that gets you points. I'm going to be the examiner. Basically, I'll throw direct questions at you, the kind you'd get in Aviva, and we'll break down the answers.
Let's do it. Direct, efficient, and evidence-based.
Okay, but before we crack on, a quick request for everyone listening. If you find these revision sessions valuable, please hit that follow button right now.
It genuinely helps. And rate the show. It gets us into the ears of more residents who are probably stressing out about the same topics.
And definitely leave a comment if there's a topic you're struggling with. We build our schedule based on what you need.
And don't forget, for those who want to go deeper, there's the premium subscription. That's where we have our journal club and clinical cases episodes.
Which are crucial for that higher order thinking part of the exam where just memorizing a list won't cut it. Okay, let's do this. Orbital fractures.
Right.
In the real world, these things rarely happen in isolation. A patient comes in, orbit smashed.
Yeah.
What else are we immediately looking for?
You have to look at the whole neighborhood. It's so rare to get a truly isolated orbit. So you're usually looking at three main associations.
Okay.
First, zygomatic fractures. The cheekbone takes the hit and the force transmits. Second, nasosoethmoid fracture, so the central midface.
And the third?
High Lefort fractures, where you've got that whole midface dissociation. Basically, if the orbit is broken, you have to check the zygoma and the nose. Don't get tunnel vision.
Got it. Okay, let's go back to first principles. Pathophysiology. Examiners love the how. There are three classic theories for how the orbit breaks. Can you walk us through them?
Yep. Three competing ideas. So theory number one is the hydraulic theory.
This is the big one.
Yes, this is the big one. It's the most widely accepted. The idea is that a blow to the globe itself causes this massive sudden spike in intraorbital pressure.
Like squeezing a water balloon.
Exactly. That pressure has to go somewhere, and it just blows out the path of least resistance. Usually that's the floor.
Okay, so that's the one they're probably looking for. But what about the other two, just in case they push?
So theory number two is the bone conduction theory. This one suggests the pressure isn't from the eyeball, but that the force hitting the orbital rim.
Ah, so the frame itself.
Right. It creates buckling forces, these shock waves that transmit through the bone and cause the thin floor to snap.
And the third?
The third is the direct globe-to-wall theory. It's exactly what it sounds like. The idea that the eyeball gets pushed back so far that it physically smashes into the walls.
It's that likely.
It's considered the least likely of the three. I mean, the globe is pretty soft. It's more likely to deform than to punch through bone.
Okay, let's talk anatomy. This is a classic Viva question. They'll ask you to differentiate the absolute thinnest part of the orbit from the most common fracture site. They're not the same, are they?
No, they're not, and that's a key distinction. The absolute thinnest part is the lamina papyracea of the ethmoid bone.
The medial wall.
The medial wall. It's literally paper thin, but that's not where most pure blowout fractures happen.
Right, so the most common site is?
The orbital floor.
So why is that? If the medial wall is thinner, why does the floor give way more often?
It likely comes back to that force transmission. The geometry of the orbit and the typical direction of a punch or a ball just favors the force being transmitted directly to the floor from the inferior rim.
You use a specific term there, pure blowout fracture. For an exam, definitions are everything. What is a pure blowout?
A pure orbital blowout fracture is one that does not involve the orbital rims. The rim is intact, but the internal wall has failed. That's pure.
Simple enough. Okay, let's flip it. We always hear about blowout. What about blow-in fractures?
Yeah, these are rarer but can be much nastier. A blow-in usually involves the orbital roof or the lateral wall. The bone fragments get pushed inwardly toward the globe.
And the big risk there isn't volume change, it's
impalement. Those bone shards can physically stab the globe or push it forward, causing proptosis. A real surgical nightmare.
Let's move to the clinic. The patient is in the trauma bay. What's the headline symptom we're looking for?
Diplopia. Double vision. That's almost always the main complaint.
Okay, but here's the trap for the junior resident. The patient has double vision. Does that mean we immediately book them for the operating theater?
Absolutely not. And this is a huge management point. Yes, diplopia is present in most cases initially, but the data shows that in over 95% of patients, it resolves on its own within 6 months.
95%. That's a massive number.
Yeah.
So how do you differentiate? How do you tell the difference between the self-limiting kind and the surgical kind?
You have to play detective and figure out the cause. If the diplopia is from edema, just swelling, or a muscle contusion, or maybe a bit of neuropraxia where the nerve is just stunned,
It'll get better on its own.
it'll get better as the swelling goes down. But the surgical kind, that's mechanical.
You mean entrapment?
Exactly. If the inferior rectus muscle or even just the orbital fat is physically stuck in the fracture line, that's not going to fix itself. That needs an operation.
Speaking of entrapment, there's the systemic risk with this, isn't there? A big red flag.
Yes. The oculocardiac reflex, it's a vagal response. The entrapment stimulates the vagus nerve, and that can lead to severe bradycardia.
So if you see a patient with a black eye and a heart rate in the 40s,
Don't just think concussion, think entrapment, especially in kids. It's a great clinical pearl.
okay, so to confirm that entrapment, we use the force duction test. Walk us through the proper protocol for that.
It's a 3-step process, and you have to be methodical. Step 1, anesthesia. You have to inject local anesthetic into the conjunctival fornices.
You can't just do it on an awake patient.
No, if they're fighting you, the test is useless, so they're numb. Step 2, you take fine forceps, you go in through the inferior fornix and grasp the inferior rectus tendon.
And then you try to move the eye.
You try to manually rotate the globe upwards.
And step 3 is the interpretation. What are you feeling for?
It's purely tactile. If you feel resistance, if the eye just will not go up, that indicates a mechanical restriction. That's a positive test.
So if it moves freely but they still have double vision, it's more likely nerve or muscle bruising.
Precisely, not mechanical entrapment.
Clear. Let's talk management. We're at that crossroads, conservative versus surgery. What do we just watch and wait?
We have 3 main criteria for staying conservative. First, inophthalmos, the sunken eye. If it's less than 2 millimeters,
Measured with a Hertel exophthalmometer.
right, if it's less than 2 millimeters, it's usually not even noticeable, so we can observe.
Okay, what's criterion 2?
If you've got a minimally displaced floor fracture and the eye movements are totally normal, no entrapment, no big defect, we can leave it alone.
And the third one is a big safety one.
Yes, this is a do no harm situation. Patients with only one seeing eye, you generally avoid operating on their injured good eye unless it is absolutely critical. The risk of a surgical complication causing blindness is just too high.
That's vital. And even if we go conservative, we're not just sending them home for good, right?
Oh, absolutely not. Regular follow-up is mandatory because that clinical picture changes as the swelling goes down. A conservative case can easily become a surgical one a week later.
Okay, now for the other side, surgical management. What are the big picture goals here? Why are we operating?
3 main goals. 1, prevent or correct globe malposition, stop the eye from sinking or dropping. 2, restore orthoscopic vision, so single vision. And 3, maintain or improve visual acuity.
And timing. When's the best time to go in?
Early repair is better. We generally aim for less than 3 weeks. After that, fibrosis starts to set in, and it's much, much harder to get a good result.
Okay, listeners, this is the part for the exam. The specific indications for surgery. Let's start with inophthalmos. What are the numbers we need to know?
You have to memorize these. You operate for any acute enophthalmos you see right away. And structurally, if you have combined medial and inferior wall fractures, if both are gone, the eye will sink.
What about isolated fractures? Just the floor or just the medial wall?
Okay, for an isolated medial wall fracture, the threshold is medial displacement of more than 3 to 5 millimeters.
And for an isolated floor fracture?
For the floor, it's inferior displacement of 3 millimeters or more.
Let's repeat that because it's so high yield. Floor is 3 millimeters or more. Medial wall is 3 to 5.
Correct. That's the volume tipping point where you start to get clinically significant, visible enophthalmos later on.
Okay. Now, what about the indications for diplopia?
First, obviously, diplopia with a positive force duction test. That's entrapment. Second, if your CT scan shows significant displacement of the inferior oblique muscle origin, if its anchor point has moved, it won't work right.
And the third?
Acute entrapment of an extraocular muscle.
Why is that different? Why is acute entrapment so urgent?
Because of the risk of a vascular necrosis, if that muscle is tightly strangulated by bone, its blood supply gets cut off. If you leave it, the muscle dies and turns to scar. It's a disaster.
Got it. Any absolute emergencies, the call me at 3 a.m. scenarios?
Yes. Retrobulbar hematoma, bleeding behind the eye. The pressure builds up, strangles the optic nerve. That is an emergency that requires immediate decompression to save their vision.
Don't even wait for a scan.
You decompress.
All right, we've decided to operate. Let's talk approaches. How do we get to the floor?
You can group them. There's transcutaneous, so through the skin, transconjunctival, through the inside of the eyelid, and transoral.
Let's do transcutaneous first. What are the options?
You have the subciliary approach, which is like a lower blepharoplasty incision right under the lashes. Then there's subtarsal in a mid-eyelid crease. And the lowest is the infraorbital incision.
And transconjunctival seems to be the popular choice now to avoid a scar.
It is. You can go through the inferior fornix, either pre- or post-septally. You can use a transcaruncular approach for the medial wall. Often we'll combine the transconjunctival with a little lateral skin extension to swing the eyelid out of the way.
And the transoral approach.
That's mostly for endoscopic assessment. It lets you look up from the maxillary sinus, but it's rarely your main approach for the actual repair.
No matter how you get in, what's the goal once you're on the bone?
You find the inferior orbital rim, and then you dissect in a subperiosteal plane. You lift everything off the bone to expose the fracture, and crucially, at the end, you must resuspend the soft tissues of the cheek back to the rim.
Why is that resuspension so important?
To avoid cheek deposis and scleral show, if you don't anchor everything back up, gravity wins, and the patient ends up with a droopy cheek.
Okay, so the fracture's exposed. Do we always have to put a plate in?
Not always. If you can reduce the fracture and it's stable, it just snaps back into place, you might get away without fixation. But that's rare and needs really close follow-up.
So most of the time we're fixing it. What's the concept there?
You're creating a cantilever. You fix a plate to the solid, intact orbital rim, and the plate extends back over the defect, supporting the orbital contents. It bridges the gap.
Which brings us to reconstruction materials. What are our choices for that bridge?
This is a bit controversial, surgeon-dependent, but for the exam, you need to know the menu. It's autologous, so from the patient, or alloplastic, which are synthetic materials.
Give me the autologous options.
You could use ear cartilage, septal cartilage, iliac crest bone. Some people use the anterior wall of the maxillary sinus, or even split calvarial bone from the skull.
And the alloplastics.
Titanium mesh is the workhorse for big defects. You also have things like Merlix mesh, or porous polyethylene medpore, which allows for some tissue ingrowth. And for small defects, you might use a resorbable sheet, like PDS.
Okay, implant is in, you're about to close. What's the one thing you must do before the patient leaves the table?
You have to perform another forced duction test after the implant is in. You have to verify you haven't trapped anything with your repair. If that eye doesn't move freely, you have to go back in.
And post-op, in the recovery room, what are we watching for?
Retrobulbar hematoma. Pain, proptosis, decreasing vision. It's the absolute nightmare scenario.
Okay, let's wrap this up. If you're a resident listening to this, what's the one big takeaway for the exam?
The measurements. Don't just say a big fracture. Give them the numbers. Isolated floor, 3 millimeters or more. Medial wall, 3 to 5 millimeters. And ophthalmos, less than 2 millimeters. Observe. Knowing those lines in the sand is what they're testing.
And I'll add one more. Remember the oculocardiac reflex. Bradycardia equals entrapment until proven otherwise.
Absolutely.
That's a wrap on this high-yield revision session. We hope it was useful.
And if it was, make sure to check out the premium feed. The Clinical Cases episodes are where we apply these facts to complex scenarios, which is exactly how the higher-level boards test you.
Please rate the show if you learned something today. Drop us a comment with the next topic you want us to cover. We're here to help you pass. Good luck with the revision.
Study hard.
See you next time on The Deep Dive.